So I'll just give a quick introduction to the new National Cancer Audit Collaborating Centre and what it means for the future direction of the prostate cancer audit. So we're absolutely delighted that we've been commissioned to create this new National Centre of Excellence to evaluate cancer care by NHS England and the Welsh Government via HQIP. So the new centre will develop and deliver 6 new cancer audits, including ovarian, pancreatic and kidney cancer and non-Hodgkin's lymphoma, in addition to 2 separate audits in primary and metastatic breast cancer. And these 2 audits replace the previous national audit of breast cancer in older patients, which successfully concluded last year. So the new centre is based in the Clinical Effectiveness Unit, which is an academic partnership between the RCS and the London School of Hygiene and Tropical Medicine, and it was established 25 years ago. And since this time, the Clinical Effectiveness Unit, or the CEU, has developed a national and international reputation for expertise in the methods, organisation and logistics for large-scale healthcare performance assessment. So the announcement about the new centre was made this summer, and the contract for the new centre started in October 2022. So thinking about the prostate cancer audit, the existing cancer audits will move into the centre once their existing contracts come to an end. So the Clinical Effectiveness Unit has been successfully delivering a number of national cancer audits. In fact, we now deliver all of the national cancer audits, and this has been going on over the past 15 years. So in addition to the NPCA, which started in 2013, we've also been working on the National Esophageal Cancer Audit since 2006 and the Bowel Cancer Audit since 2010. And recently the Lung Cancer Audit joined us last year. And as I mentioned, for the NPCA, once it comes to the end of its current contract, which is at the end of June, it will move over into the new centre from July. So the design and delivery of the new audits in NATCAN will be very much informed, as you would expect, for our experience in the CEU working on national cancer audits over many years. So NATCAN will maintain key features of the existing audits, a number of which we've discussed in detail in relation to the NPCA today. So this includes, and is incredibly vital, is close clinical and methodological collaboration, and also close links with all stakeholder groups. So this includes both clinicians and, very importantly, patient charities and patients themselves. So as we do in prostate, the new audits will continue to work in close collaboration with the cancer registration services in England and Wales, using only national routine data sets. So as both Matt and Jan have described, this will make the process of producing relevant and robust performance indicators more efficient. And this will continue to underpin our audit reporting. As Matt also illustrated, the research and development underpinning, Matt has demonstrated to us earlier this morning, that research and development very much underpins the success of the prostate cancer audit. So we'll take the same approach for each of the new audits. So this will be informed by methodological development. So this will make the outputs of the new cancer audits more robust and enhance their technical rigour. So a couple of examples here from prostate. This will also include a clinical epidemiological approach, which Jan emphasised. So we'll investigate determinants of variation in practice and outcomes to make outputs more informative for quality improvement. In addition, we'll carry out health services research. So this includes determining the structural organisation of NHS cancer services in order to target quality improvement initiatives appropriately. So what will we do differently? So used appropriately, the recently available rapid cancer registration data is a key innovation that will allow more timely, within 6 months after diagnosis, and more frequent reporting on a quarterly basis. Instead of the usual detailed annual reports, we'll develop concise state of the nation reports on the basis of the gold standard data, and these reports will be limited to 10 pages and a maximum of 5 recommendations. A further innovation will be to use the rapid data to close the audit reporting and feedback cycle using planned use study methodology and then evaluating the impact of implementing change. So these innovations will also be relevant in the new phase of the prostate cancer audit when it moves into NATCAN. So I won't go into huge detail. There is we have a very detailed program plan, and I'm very happy to discuss with anyone after this meeting. So as you can imagine, the first year is a hugely busy yet exciting period of development for us in the clinical effectiveness unit. So we're currently building organisational and governance structures, both at a centre level and individual audit levels, recruiting staff, recruiting clinical leads, for example. We'll carry out mapping of cancer service configuration, create common data access channels with our data providers, and scoping, developing performance indicators and designing bespoke QI plans for each of the audits. At the start of the second year, reporting and feedback of results will start, followed by the rollout of QI initiatives. So for the NPCA, in advance of the NPCA moving into the centre from July this year, we will carry out a scoping exercise working with our stakeholders, and we'll pick up some of the key themes. For example, the work that Joe shared about looking more closely at patients with metastatic disease and the treatments that they receive, and in line with developments in treatments of metastatic prostate cancer. So we'll carry that scoping exercise will take place in the coming months. So my final slide just brings together a number of different highlights related to the centre. So each of these are key themes which we've covered in this session, in this second session today. So we'll continue to use routine and more rapidly available data sources, working collaboratively with the cancer registration services in England and Wales. We'll develop clinically relevant and methodologically robust indicators to enable us to carry out fair comparisons of providers. We'll apply a clinical epidemiological approach, and this will inform all of the quality improvement activities, including using the rapid data, continuous monitoring, reporting and improvements to that reporting and data visualization and feedback to close the audit cycle. Targeted and appropriate communication with all stakeholders is key, as is establishing clinical reference advisory groups. And we're also in the process of establishing a team of national and international experts who have extensive experience in QI and implementation research. As we do in prostate, each audit will set up a standalone patient forum, which is absolutely essential to the work we do, and we'll work collaboratively both with patients and the patient charities to establish this. And we'll also apply for external funding, for example, from the NIHR, to support aligned research projects, including both national and international collaborations. So I think the key messages and meaning for the NPCA is that, it's a fantastic opportunity. All these cancer centres being within the same, sited within the same place, will enable us to have more joined up thinking, learning across cancer audits, and of course, the creation of a bigger critical mass, both within the sort of infrastructure within the department, but also working across a broad range of stakeholders. So finally, I just wanted to thank you all, to take this opportunity to thank you all for your support since the NPCA started in 2013. And I really look forward to working with you in the new phase of the NPCA, as do all members of the NPCA team. So thank you.